So Dr. Brosco is the director of the Division of Services for Children with Special Healthcare Needs from the Maternal and Child Health Bureau at HRSA. His full bio is on the meeting website, so if you're interested in learning more about him, check that out. He's joining us from California this morning, and so we thank him so much for taking the time out of his meeting to talk to us today about HRSA's vision for children and youth with special healthcare needs and the path forward in newborn screening. We're going to take all questions at the end, but please, if you think of questions while he's giving his talk, go ahead and put them in the chat, and I'll kind of keep track of those. And so you could do that during the talk, and then we'll address them then. So Jeff, I will invite you to share your screen. Thanks.
Oh, thank you very much, Michelle. I didn't realize that I was sharing my screen. I thought you guys had my slides. So I don't know if that's possible or not.
Second, I can grab the slides.
Yeah,
That would be good because I'm not sure. I think the latest ones you guys have. While we're doing that, first of all, thank you for calling me Jeff. If anyone calls me Dr. Brosco, as you know, Michelle, I hang up. So let's make sure we keep on that one, especially when we get to the questions and answers. Just a little bit more on my background so folks know who I am. It's true I've been with HRSA MCHB for a year and a half now, but I am a pediatrician first and foremost. And I have a general pediatrics practice at the University of Miami. Have had it for 30 years. I still see patients and families on Monday afternoons. And I specialize in development of behavior. So my general peds practice over the years really has become a lot of kids with autism, ADHD, but complex conditions, and as often happens at a university general pediatrics practice. So I'm very much a clinician, but I also had a series of roles in the state of Florida, including being Deputy Secretary of Health. And so was overseeing a newborn screening program, our deaf and hard of hearing EDDI program, our Part C programs. And we actually had a managed care organization within our Department of Health with 65,000 children that had special healthcare needs in it. So I had a little bit of experience on how you get a managed care organization to work or not work, as sometimes that may happen. And at the federal level, I've been involved in the advisory committee for newborn screening for years and years. So I have a lot of different experience, even though I'm relatively new to HRSA. And I really look forward to having a conversation. I'm going to spend some time telling you about our vision so you can understand what it is we're trying to do. But I do hope that we have some time for conversation at the end. Could you go to the next slide, please? Which I think says I have no disclosures. It's always easy as a Fed. And you can go to the next slide. So just to kind of orient everyone to what HRSA is. So this is the Department of Health and Human Services. So this is the huge organization. And if you look on the left, you'll see there that there's toward the bottom is the CDC. I think we all know as the CDC helps us keep track of our nation's health. Below that is CMS. And that is the trillion-dollar organization that pays for Medicare and Medicaid. So it's really is the major payer for healthcare services in the United States. If you look in the bottom right, you see NIH, and that's where obviously a lot of research happens and the innovation. And then you see HRSA. So what's HRSA's role in all of this? Well, if you think of NIH, their job is to come up with new ways, innovative ways of taking care of healthcare issues. It's our job at HRSA to make sure that everyone gets the healthcare they need. The children get what they need so they can play, grow, go to school, become a healthy adult. And I've often said that, if we had a perfect healthcare system and there were no racism and no poverty in the world, you wouldn't need HRSA. But because there are those issues, we have to fill in the gaps and try to make things work as best we can. Next slide, please. Within HRSA is Maternal Child Health Bureau. You see us there at the bottom. And obviously we focus on child health, maternal health. We are tiny in terms of our overall budget, but we tend to have a fairly large role in how the nation thinks about maternal and child health. Next slide, please. So this is our maternal child health strategic plan. And you can see our vision is the health and well-being of America's mothers, children, and families is improved over time, and that they're all thriving and reaching their full potential. And you see across there access, can anyone get what they need? Equity, we want to make sure every person gets what they need. And then building up the public health capacity. So do we have enough folks who have expertise? And they're really making a difference. Next slide. And then within Maternal Child Health Bureau is the division that I run for children and youth special healthcare needs. There seems to be a little delay in the slide, so I'm sorry if I'm ahead of them or behind them. Before I get to, I'll see my division at the bottom, but just to remind folks that there are lots of ways that you interact with MCHB. So newborn screening is one of them, but in maternal health, infant mortality, home visiting services, poison control, emergency medical services, a lot of things we do. Next slide, please. And children and youth special health care needs are a part of that. As I jump into that, though, I want to take a minute. I think we're going to do a Mentimeter thing where we're asking you to all think about, just for a minute or two, what are the 3 most significant issues for the health of all children in the United States today? So just come up with a couple things that you think are important, and Erica will help figure out how to do this to add them in, and we'll see what you guys all say.
Yes, go ahead and click on the link in chat to answer that question, and your answers will appear as part of a word cloud and they will be anonymous. So Alyssa, I'm going to take over the screen sharing for a moment so we can see those answers coming in.
This is great. So I'm seeing mental health, access, poverty, gun control, food insecurity. I do see rare diseases there, which I think befits this particular audience. Mental health keeps getting bigger. Poverty is still pretty big. Obesity is showing up. You guys notice that gun deaths are the #1 cause of deaths in children in the United States. So this is a group that knows it's public health. Nutrition coming up higher. This is great. It's getting small enough that I really can't see them anymore. It'd be nice to take a screenshot of this and so we can keep track of it. My colleagues would like to see it too. Erica, could we go to the next slide? So I've done this sort of question a lot with folks over the years. So, and you can see that this is kind of what typically comes up. Poverty, access to healthcare, schools and homelessness come up in a lot of lists. You see I have listed at the bottom left, AIDS, Zika, COVID-19, and then there will be one after this, right? There's always a new emerging infection. Car crashes used to be the leading cause of death for children. Now it's gun violence. And on the right-hand side, you see a variety of things as well. Maternal depression comes up in a lot of audiences. At the bottom, I have written there just a reminder that every child needs at least one loving, consistent caregiver. That seems to make up for a multitude of sins if you have at least one person who's in your life and consistent. Next slide, please. Having thought about this, what are the issues for child health in the United States today? Which of these are going to be solved by pharmaceutical or genomics innovation, or by admission to a hospital for tertiary care, even quaternary care? Or if you're a pediatrician like me and you see someone for 15 minutes, how much can I do about poverty, substandard schools, gun control, and so on? And obviously my point is that the issues that are really important for most children in the United States today tend to be what we think of as the social determinants of health. It's what happens in neighborhoods, it's what happens in schools and in families and so on. And what many of us do, and I know we're not all clinicians, but what many of us do is a very narrow slice of the world. It's a really tiny part. Next slide, please. Now, that having been said, this is really important to focus on rare disease. And this is a child that I saw, I still cover for emergencies on Saturday mornings. This is now a few years ago, but Carolina came in, 7-year-old girl, and she had a rash. And I'm not going to go through the whole list of things that were important in her life, but she has her underlying condition, septo-optic dysplasia. The details of this don't really matter, but it has a whole series of medical complexity that made it really a challenge for her family to meet all the needs. So what medicines she needed, her G-tube, is that working? And so just having a simple rash is a big deal. Is it one of her medicines that do we need to change that? Is it a serious infection? Because it could be much more serious. Whereas most 7-year-olds who have a rash, I can take a quick look at as a pediatrician. Yeah, this is a rash. It's going to go away. Don't need to do very much about it. But for a girl like Carolina, that's a much more complex situation. And for her family, it can really throw a wrench into whatever's happening. Next slide, please. But I would also say that, so this is one point, right, to make it clear that I'm not suggesting that genomics pharmaceutical work isn't important. I mean, you think about nusinersen for spinal muscular atrophy. It's really almost a miracle to imagine that kids with SMA in the past who never really would have been able to walk or participate physically in the world are able to do so now, right? So I don't mean to minimize the extraordinary things that can happen in laboratories or in hospitals. They save children's lives all the time. And I do think visits with me are worthwhile and my peers. I mean, I think we can do a lot with families during that time. For kids like Carolina, though, it probably needs to be something like a complex care health home. If you have just a single clinician, a family medicine doc, nurse practitioner, or pediatrician, it's typically not enough. You need a team. You need nutrition and social work and mental health providers. You really need to be able to do a lot more. Family navigators. Next slide, please. And I would say for children with medical complexity like Carolina, they have obviously a greater dependence on the healthcare system. And this in some sense makes them triply vulnerable to social determinants of health. So SDOH are really important, right? So if a child has asthma or a lung condition, then their air pollution is going to be much worse for them. And if they have difficulties because of economic reasons or whatever reasons with transportation, then that limits their access to healthcare. And we know that children with chronic health conditions suffer the greater economic burden. So it's not like the social determinants of health are not important. In fact, they're triply important for kids with medical complexity. Next slide, please. So I spent a little time talking about this to give you a sense of the epidemiology of child health. On the right-hand side of this, you see allergies and asthma. Most of those children have relatively mild allergies and asthma. So those 8%, 9%, 10% of kids typically are doing pretty well unless they have an exacerbation. Things like diabetes and sickle cell disease are around 1 in 1,000. And then you get into things like liver transplant, or which are 1 in 500,000, or septo-optic dysplasia similarly. And then there's 13,000 more rare conditions. So child health tends to be focused on very rare, very numerous conditions. And then on the left-hand side, you see where a lot of the action is really in terms of epidemiology in the US. It tends to be about developmental behavioral disorders. About 15 to 20% of children have a significant behavioral, mental health, or emotional disorder that affects their everyday lives. Next slide, please. So this idea of children with special healthcare needs is a way of dealing with this extraordinary complexity of epidemiology by having a single category. And it was developed really by families and a few epidemiologists and pediatricians in the 80s and 90s. And basically what it says is that a child with septo-optic dysplasia or cancer or sickle cell disease, that they tend to have more in common as children, as a family, than kids who don't have underlying complex conditions. Next slide, please. And this is really important because it turns out that we have to think about them as a larger group. You can't see this probably. It just shows you that at the very top of the SHIN population, and that's how I'll use children with special healthcare needs, so I don't have to say it over and over again. The SHIN population, if you look at the conditions that are in that, it's largely things like allergies and ADHD, and then a whole bunch of behavioral disorders. Asthma fits up there too. And you can't see at the bottom, but there's cystic fibrosis, and it's 0.0000. Just as a reminder of how rare conditions are. Next slide, please. Now, this group of children, it's about 1 or 2% of kids that we think of as medical complexity, are a subset of the larger SHIN population, and they're the ones that have the greatest medical technical needs. They're a small number of children, but they're 1/3 of our healthcare spending and 40% of deaths. So they really are a critical part of our healthcare system. Next slide, please. So this kind of puts it all together. So you have all children, and then you have this SHIN population, which is around 15 to 20% of kids overall. And then you have the CMC population within it. And that's a lot of the families and children that we all deal with, or we are in this particular conversation we're having today. Next slide, please. One of the reasons why I am doing the work I'm doing, and you're all doing the work we're doing, is that our SHIN families and children are not thriving as well as they can. And here you see on the left-hand side, comparing the SHIN and non-SHIN populations for things that really matter, like flourishing. How well is your child doing? Are they curious? Are they participating in the world? Are they doing the things you want them to do? And school engagement. And you see there's like a 30-point difference between SHIN and non-SHIN. And on the right-hand side, we're looking at how our families are doing. And I have parental physical health, but mental health looks the same, and parental employment. And again, you see there's huge differences between how the SHIN and non-SHIN populations are doing, suggesting we have a lot of work to do. Next slide, please. So to address this, we have something called the Blueprint for Change. And here, just as sort of the steps, the key thing to know is there's a multi-year process involving families, clinicians, public health folks, people inside and outside of government. Next slide, please. And it resulted in a publication in Pediatrics, and you can click again. And it's a series of 8 publications that are now almost 2 years ago came out. And they lay out a really extraordinarily visionary approach to child health. There are 40 strategies that suggest that we need to change the way our system works. Next slide, please. And to kind of boil this down, there are 4 kind of key components of this. You see access to services and financing of services as 2 key things. We've been doing that for a long time at HRSA and trying to focus on it. What was new that we heard over and over from families was quality of life and well-being. And that is, they don't want us just in our healthcare system to measure things like, has a child been vaccinated, or did they get to their doctor this year for a regular checkup? They want us to look at things like, is the child flourishing? Are they going to school? Are they playing? Are the families doing well? And health equity was also a big thing. Are we reaching every child? So if you can click again, we kind of put this together and say that is every family able to get what their child needs so they can play, go to school, and become a healthy adult. Next slide, please. There's a lot built into this. Every child gets the services they need. Notice it doesn't say that every child gets the same amount. So that's an equity statement. They get what they need. And play, go to school, become a healthy adult. You see built in there quality of life, a transition to adulthood. And we want grownups and siblings to thrive because family well-being is probably a really good way of knowing whether the system's working and whether children are doing well. Next slide, please. So how do we actually do that? And I'm going to go into this just for a second because I think it's going to be critical for understanding why HRSA is moving our investments the way we are. So we think measuring what matters and creating a system that is self-correcting over time is the best that we can do. But we need to measure what really matters. So you see a few things on the left there. We want to do this at a population level where we're trying to reach every single child. And we want to have some accountability in how the system works. Next slide, please. So this is just one example. Probably a lot of you are familiar with newborn hearing screening, our EDDie program, early detection of hearing and intervention. And it's a newborn screening program, just like the blood spot program is. So every state has its law that says every child needs to be screened within a month of age. If they don't pass the screen, they need a diagnosis by 3 months of age. And if they have a diagnosis of deaf or hard of hearing, then we start intervention, support the families, connect them to the medical home, and so on. And so the idea is you can kind of imagine this pipeline where this is how the system is supposed to work. And at the end, in the EDDie world, it's children achieving language milestones. And so if the system's working perfectly, however many children you start with, at the end, every single child is thriving. And the way HRSA hopes to make this work is asking states to actually measure it in their state and say, well, what percentage of 3-year-olds are thriving in your state who are deaf and hard of hearing? And if it's below 100%, which of course it will be, what are the things we're doing to improve it? And really importantly, we're going to ask states also to disaggregate that data based on historically underserved groups in their state. So if it's rural populations, Native American tribes, race, ethnicity, what are the things in your state or region that matter? And are those groups, what are their language percentages? And if they're lower than the average, what are we doing to help them in particular? So this is the way we try to imagine trying to measure what matters, get to what's most important, and then create a system that's accountable. So if we find there's one group that's not doing well, or, what's the issue? Are we not doing the diagnosis properly because we're not reaching those families? They're not showing they're available for follow-up. So then we would have a quality improvement plan, measure it again and see how we're doing. And you'd have a continuous quality improvement approach. Next slide, please. Now, that's the pipeline looking easy. Reality is way more complicated than that. And so just sort of mapping out how any system is supposed to work is a big challenge for every state. Next slide, please. And we also know for families, it's not a pipeline at all. It is a forest with no clear direction. So a lot of our work is supporting youth and families and how they get through this sort of thicket of things they need to make it through. Next slide, please. And I'm not going to go into the details of this, but we are at HRSA, MCHB, funding a variety of things for the entire SHCN population. So that obviously that includes children who have genetic disorders. Family engagement, I'll talk a lot about in a minute, but it's one of the key parts. And excuse me, Family Voices is our grantee here, and they are responsible for family engagement nationally across the board in all of our grants. We have a research network. We also are working with the AAP on the system of services more broadly, and then particularly for children with medical complexity and trying to make sure every child has access to a complex care health home. Next slide, please. Now, the regional genetics networks, you guys know this well, but much more than I do, because many of you have been part of this over the last couple of decades. And I just want to take a moment and celebrate and say that the work of the regional genetics networks has been extraordinary and produced many great outcomes, and NIMAC in particular. Next slide, please. What we are doing now is shifting to thinking at a systems level about newborn screening in particular. So you recall I said at the beginning that if we had a perfect healthcare system, no poverty, no racism, then you probably wouldn't need HRSA. But there's an exception here, right? I mean, things like newborn screening wouldn't happen typically in a healthcare system where you wait until someone is sick and then you treat them and get them better. For things like newborn screening, where you have a universal program looking for extraordinarily rare conditions so that those children don't miss out on what they need, that they can get intervention before they have symptoms, you need to have a public health program. And because that public health program is something that we're doing in a fairly, I mean, let's face it, in most states it works out to be mandatory, even if there are some ways you can opt out, we feel like we have an obligation to make sure that system works really well. So this is why HRSA is shifting its investment from regional genetics networks into making sure that state newborn screening programs are functioning as well as they can. So I'm going to spend a few minutes going through what HRSA's role is in newborn screening programs, just to give you a sense of that. Some of you know this really well, and it'll be a repeat, but for others, it may be sort of new. But I'll still try to be quick so we can have time for conversation. So one thing is the Advisory Committee on Diseases in Newborns, Hereditary Diseases in Newborns and Children. And their objective is to help states reduce morbidity and mortality. They provide recommendations to the Secretary of HHS, and they do systematic evidence-based recommendations. Next slide, please. So one of the things we do is we support our evidence-based review group. So when a condition comes up for possible addition to the RUSP, that's the Recommended Uniform Screening Panel, that would be then added to most state panels, we do an evidence review to see what does the evidence show about, is this a condition that has a treatment that is started in the newborn period, improves outcomes compared to clinical. Next slide, please. And this is the decision matrix that they use. I'm not going to spend any time on that because it's not relevant for you guys. Next slide. More importantly, I think for this audience is we are supporting state newborn screening programs. And the key thing is to think about, first of all, that newborn screening is a system, it's not a test. So it's not really that there's a test for PKU or for hypothyroidism. It's then that we are able to contact that family, connect them to a clinician, and they get ongoing care that improves outcomes over the long run. And I'm going to tell you in a minute a little bit about some of our programs. Propel and Co-Propel are our new state grants. We also have a national coordinating center to try to pull this all together. And the key things for these grants altogether is to help states implement new conditions as they get added to the RUSP, to make sure that we are connecting families with the results and with clinicians. That's the new steps, short-term follow-up, but also start looking more carefully at long-term follow-up. Are these programs really working? Are they effective? Are children getting what they need so they can play, go to school, become healthy adults? We also have a role, besides these state newborn screening programs, in condition-specific programs, and I'll tell you about sickle cell disease in a few minutes. Next slide, please. So here are our Propel grantees. These are the states that are just started this past year. We are very close to finishing up our Co-Propel review, so we'll be adding probably about 10 more states to this. Our goal would be eventually that every state is supported, just the way we do in our EDDI, Deaf, Hard of Hearing program, where states have the infrastructure support they need to make their newborn state programs, screening programs work well. We're also, in the way we did this with Co-Propel, recognizing that for some states, this is hard to do, to write these grants and connect to the federal government. So are allowing for partners, and these can be universities, they can be regional collaboratives, to work with states to be the PI on the grant. So states can get the benefit of the work without having to be the direct recipient of it. Next slide, please. So this collaboration, so we have newborn screening Propel and Co-Propel, and those are the grants that go straight to states. And as I mentioned before, focusing on adding new conditions and short-term and long-term follow-up. APHL is our national center, our NBS Excel, and they're responsible for supporting states in this work and providing national leadership. And I mentioned at the beginning how important family engagement is. And so we have, as part of that, built into APHL is the work for Expecting Health, but we're also connecting our broader FELS grant there. Next slide, please. Just a word about long-term follow-up. For nearly 2 decades, we have recognized that we are not doing a great job at finding out whether this newborn screening, this program we invest so much time and energy into, is it really working? Are families really getting what they need? And so I have here some of the papers that have come out from the advisory committee. Next slide, please. And so our goal, and we're working very closely with CDC and NIH and other partners on this, is to start thinking about where's the data. So can we build something in newborn screening like we have in EDDI? That is to say, do we have a way of measuring how well the system is working continuously over time so we can see where the problems are, where the leaks are in the pipeline, and fix them? That's the basic idea here. And I'm not going to go into the details of this, but basically data can fit into the newborn screening results themselves, whether those results lead to a specific diagnosis of condition, that's bucket number 2, and then how families and children do over the long term. Next slide, please. Again, the details are probably too much for you guys, but just to give you a sense of how we're doing this, we worked with a number of our grantees to say, well, what's the data that we really need? There's public health data, there's clinical data, there's clinical care data, but there's some core stuff that we can probably follow. Next slide, please. I think you have to just keep clicking until we get through this. I tried to remove all this stuff, but I'm sorry it's still there. Okay, just want to spend a minute talking about family engagement, because we at MCHB HRSA have been leaders in this for the last really 3 decades. And the basic idea is that unless you have families involved at every level, thinking about clinical, how the clinic works, thinking about local policy, state policy, national policy, unless families are involved and have a clear role, you can't do things the way you want them. They're just not going to come out right. So we have our national FELSC, Family Engagement Leadership and Systems of Care, who are providing leadership about how to make sure that, number one, that families are well trained to be able to participate in this kind of work. Next slide, please. They also provide support at the local level. And just at the bottom, take a look for a second. So 20% of our overall budget goes directly to families in one way or another, community-based organizations. And of our 300 or so grants, more than 100 of them, the PI is a family community-based organization. And this is in every state and territory. Next slide, please. One thing that this group I'd like to hear more about is we're trying to think about what is the model of family engagement, because we have this in all of our grants, but we're not always thinking as clearly about it as we can. And I say that we, meaning MCHB. And so the way we're starting to think that makes some sense is to imagine, if you start at the bottom of this pyramid, that families and caregivers themselves are thriving. And for a bunch of reasons, right? I mean, if families are thriving, that is a good thing in and of itself. It should be a goal of our healthcare system. And when you start thinking about what measure could work, for deaf and hard of hearing children, language acquisition is a pretty good one. But what about the 13,000 other conditions? What are you going to use in that circumstance? And since every condition is slightly different, you can't have 13,000 different outcomes. But it may be that family well-being is sort of the single common denominator across all those different conditions. So if we're measuring how families are doing, in some ways we're measuring how well the system of care is doing. The next level up would be that, you can go back to that slide, that families are doing so well that they're able to support and help their own child. They have self-efficacy. I am able to get what my child needs so they can thrive. And that's a great thing to make sure that our entire system is aiming at. The next level up of family engagement might be, I'm doing well, I'm helping my child, I'm ready to help other families. And family navigator programs, peer navigation, has been an effective model across the country. We have one at our University of Miami program that is amazing, because families who've been through the system know how it works way better than someone like me, a pediatrician, who thinks he knows how it works. And then kind of at this highest level, our families were able to participate in policy, local, state, regional, or national, and they can think about things at a systems level. So I'd be interested during this discussion period what folks in the call think about this model of family engagement. We're working on this with Family Voices and other partners. Next slide, please. Just quickly to sort of round up what HRSA does. I mentioned before that we help state newborn screening programs, but we also help specific conditions. And this is based on legislation. So, as you guys all know, government cannot do anything unless there is a law saying do this thing. And among our legislative authority is one for sickle cell disease. It is a national disgrace that we are not doing better for children and adults with sickle cell disease. Fewer than half of children are getting the evidence-based care they need right now. We recognize that there's a lot of excitement about gene therapy, in fact, be a game changer, just extraordinarily important intervention for some individuals. But right now, fewer than half of kids are getting hydroxyurea, penicillin, or just routine care. So we are spending a lot of time working on that. Next slide, please. by investing. And so we have our 5 regional centers for sickle cell disease across the country. You'll see these are university centers kind of at the heart of each of these geographical regions. And then they partner with hematologists and other clinicians across their region to make sure that every person with sickle cell disease has access to high quality evidence-based care. It's hard to see because there are different colors there, but they also partner with 25 community-based organizations that are responsible for helping with when a child is first diagnosed through newborn screening, connecting them to the various clinics that they need. Next slide, please. And you can keep clicking until the slide goes through. And this just sort of lays out how all these different programs for sickle cell disease work together. I'm hearing another voice. I think it might be Richard Pedersen. Oh, thank you. Keep clicking until we keep going. One more click. So you can just see that about $14 million a year is invested in sickle cell disease across our country to try to make sure that every individual, adult or child, gets access to the care that they need. Next slide, please. So this is how you might imagine that pipeline working for sickle cell disease. Should look a lot like the Eddie one. And our hope is to be able to do this across various newborn. We also believe that if we can get the system to work well for deaf and hard of hearing, sickle cell disease, newborn screening conditions, that we will then have a great impact on the system overall. Next slide, please. I'm not going to spend too much time on this because some of you are really interested in newborn screening, like Michelle and I, and others are like, it's not such a big deal. I will point out that the National Academy of Science, Engineering, Medicine is doing a sort of a big committee study right now to try to help us figure out what the future of newborn screening should look like. Should it continue to be really focused on what we call public health emergencies? That is, conditions that every family would like to know because they need to have that information to intervene quickly. Or is there a broader role for having information that would be useful? It's good to know that my child has this because I can plan differently for the future. And there are lots of pros and cons on both sides of this. We can talk about it a little bit in discussion, but I'm not sure that this audience is as interested as some of the rest of us are. Next slide, please. So I tried to go through this conversation as quickly as I could, just to give you a sense of where HRSA is. Our bottom line is that we want every child, like Carolina, to grow and thrive, be able to play, go to school, become a healthy adult. You see here a quote from one of everyone's favorite philosophers, Fred Rogers, talking about how no child is perfectly whole in mind, body, or spirit or ability. And we just, every family has to take their child where they are and try to move them as far ahead as they can. And it's our job at HRSA to make sure that that system of payment and research and epidemiology works as smoothly as possible. Next slide, please. So here's the contact information for me personally. I'm always eager to hear from folks. And then the other people on our team, our division is 29 people, and they are amazing. They work night and day to try to get things to work well past their hours. I'm trying to get them to stop working on weekends. They won't do it. But you see here the folks that if you wanted to reach out for any of these particular grants that we run. Next slide, please. And here's more about the Blueprint for Change, if any of you wanted to be able to learn more about it. And I think there's one more slide at the end just for HRSA. So I think we can stop the slides, and I'm glad to take questions, and I'm sure that you guys have lots of things that you'd like to hear from me. And this is the part I like the most. So I tried to get through my presentation as quickly as I could.
Thanks, Jeff. So we have a little less than a half hour for discussion. There is a couple questions. I appreciate your joining us for this and to sort of give everybody that really good overview of the Bureau and where you're headed. We do have, let's see here, one question we have is, will there be any collaboration between HRSA and biopharma that's now offering gene therapy for sickle cell to help make the opportunities available? Again, this gets back to sort of that equity question.
Sure. And so I have to be very careful about how I talk about this because I am HRSA. And so we are not the payers for things like gene therapy. Right. What I can tell you is that my partners in CMS, so that's Medicaid and Medicare, are thinking about innovative ways to do this. and are working directly with state Medicaid and with pharma to think about how could they set up a model. Because as a lot of this is $2 million, $3 million. The same thing comes up for a lot of the rare conditions that are coming up on as possibly being added to the RUSP as well. So we do have to think about this. Just to give you a sense of budgets, I think back to my days in Florida when I was the Deputy Secretary of Health, and my budget to try to manage our HRSA systems of care, right, where we try to fill in the gaps, my budget was $9 million. So I could do gene therapy for 3 or 4 kids, and that would be my entire budget. And there are 800,000 children in Florida with a special healthcare need. So focusing on those particular kids and their rare disease, I could run through my entire budget and not help 799,000 other children. That $9 million was small compared to what our managed care organization was. So for those 60,000 kids, that was a budget of about $1 billion, close to 900 and something million. So in that case, you can start to see how $1 million here, $1.2 million you could kind of work through, but still that's a lot of money for any one child. Medicaid in the state of Florida is $35 billion with a B, so it starts to get enormous. So part of what I would hope you could see from this is that the way we fund research and HRSA, MCHB are sort of these little small amounts of money around the edge. The healthcare system really is driven through both private insurance and Medicare and Medicaid. So paying for things like gene therapy has to come through those sorts of systems. And how you do it in such a way that we know that that money is well spent is a good investment. I think most of it would say, if you can cure a really, challenging condition with $1 million or $2 million and you save the healthcare costs down the line, that's fantastic. But we also don't want to do it if that doesn't actually work. That would not be a good use of resources. So there are a lot of thorny questions there. And I can tell you that HRSA has been participating in it, but really it's been our colleagues at CMS that are driving a very thoughtful approach to how we could make sure that something like gene therapy for sickle cell is available for everyone. I will also say that my voice in a lot of these conversations has been, yeah, but there are 100,000 people with sickle cell disease, and we know right now more than half of them are not getting the things they need, like penicillin. So let's make sure we don't lose track of getting every kid what they need while we're also thinking about gene therapy.
Yeah, thanks for that. As you mentioned, my heart and soul is sort of in newborn screening. And that's a question that comes up quite frequently when talking about sort of the common conditions, so everything we do is rare for the most part when you think about it. But there are things that are sort of more common. And there's been a little bit of work, and I think we're trying through APHL to do some more of this work looking at disparities in the downstream piece. So newborn screening does a pretty good job of finding the kids and getting screen positive kids. But when you start to look at different populations, whether it be broken down by urban, rural, by ethnicity, whatever, ancestry, you start to see disparities in how quickly they get treated. So I'm just wondering if this is sort of maybe a focus in the future of how to really look at that in a systematic way.
Yep. I think it's a fantastic question, Michelle. And I think it gets to the heart at what we're trying to do. And I hope a little bit came through. I know in formal presentations, it's sometimes hard to get the gist of things, but that's exactly what we're trying to do. And it might be helpful to think about the epidemiology of common stuff like asthma, ADHD. That's 5 or 10% of kids. And then ultra rare things, right? So Krabbe disease is 1 in 250,000 children, and a big state like New York can screen for a couple of years and not find any. So, but then in between, and I think of that things like diabetes, sickle cell disease, deaf and hard of hearing, where a state's going to have a few hundred children every year who are diagnosed with those conditions. And part of what's difficult about our healthcare system is that the way we hold the system accountable really only works at the population level. So if you think about how could a Medicaid or other payer hold providers responsible, they're going to think about the whole population of children. So they're going to ask about immunizations and childcare visits and things that are common. And maybe they can ask about things like, are they ready to start school? Are they graduating high school? Measures that really matter. But again, that may not be relevant to a child who has cancer or sickle cell disease or septo-optic dysplasia. Those are ultra rare things. So how do we find a system that's self-correcting for that? So that's a lot of what I've been proposing, at least for those small populations, not the ultra rare, but things like sickle cell disease and deaf and hard of hearing and things like that, where you could imagine that a state as a whole could start to think about, well, how is our population doing in our state? What are the things that are working and not working? And as we talked about, Michelle, disaggregating that. Now, it's going to be really small numbers, but we start then to have a system that's accountable. Right now, the way it works is the rare conditions get totally lost in the system. Another way to do this, right, is as I've sort of tried to suggest, is this idea of children and youth special healthcare needs, and then looking at the children with medical complexity in particular. So I think a lot of you know that one of the things we do at MCHB is we fund the National Survey of Child Health. So that's an annual survey of families. It's about 60,000 families that participate, and it gives us state-level data. It's not clear how well it does on the ultra rare conditions because they're so rare that even if it's 60,000, you may not capture them. But we're trying to work with that data set to figure out, could we identify the children with the medical complexity within that larger group? And then at a systems level, say, well, how well is New York, California, Texas, Massachusetts, how are they doing with that population? And the nice thing about that national survey is it asks lots of questions that are really relevant. Like, is a child ready and healthy for school? Is the family flourishing? So we could look at outcomes that matter beyond the healthcare system, right? The healthcare system tends to look at billing data. Did you bill for an immunization? Did you bill for a well childcare visit? It doesn't get anywhere near how is this family doing? Is this child healthy? It can only tell you whether they've been to the emergency room and what medications they've had. So what you're pointing out, Michelle, is exactly where we want to go, trying to create a measurement system of accountability that allows us to reach every child and measures the things that matter.
Thanks for that. I appreciate it. We have a couple comments about training family as advocates and sort of engaging families in advocacy. And NIMAC and a lot of the other networks have put a lot of time and effort, and we have some advocates that have worked with us for as long as I've been involved in NIMAC from our region. And they've really worked hard doing navigator training and, being sort of right-sizing us and making sure that we're doing things in an effective way, kind of as we heard prior to you joining, probably some comments on that. And I'm wondering if you have any ideas on how we can channel these parents who are very enthusiastic and want to kind of in your pyramid, want to help others and kind of keep those resources going.
Oh, I have so many ideas about this, but well, I'll try to keep it brief. So as I tried to make it clear, this is absolutely essential to all the work we do at the Bureau. And just to give you an example of kinds of things that we do for our EDDI newborn screening program for deaf and hard of hearing children, we have written that every state's budget, so we give money to each of the 59 states and territories, 20% of their budget has to go toward family engagement. And we allow them to think about different ways. Do they partner with community organizations? Do they include people on their staff? We give them some flexibility, but that has to be part of what they do. And we're moving in that direction for all of our grants. Family Voices, as I mentioned before, is our national leader on family engagement. We also fund 59 family-to-family, F2Fs, family information centers. And they're sort of like I think a lot of you probably already know I think of them as parent-to-parent because that's what it is in Florida, but that's in the education world. So they are kind of work together, the education folks and the healthcare folks. So every state has an F2F. If you haven't reached out to them, it's probably worth it because they are relatively small organizations, most of them at the state level, and they are always looking for families that are eager to take on leadership. And this is absolutely critical because if you don't know this already, you need to know that most child health policy happens at the state level. So yeah, you get people like me at the federal level who say, let's do this and let's do that. But it is the state Medicaid office, the state education office, the state behavioral health office, state Part C program, the state newborn screening program. They are the ones that are really making the decisions about what's going to work and not work. So family advocacy, family engagement and policy at the state level is probably the most important level to be involved. And so every state has a PTI. Thank you for putting that in, Tara. I couldn't come up with the acronym. I'm lousy at remembering my acronyms. I'm the worst fed of all time. So every state has a PTI. They also have an F2F. I will point out, if you don't know this, that the F2F authorization, legislative authority, ends in this year. And it's a mandatory program. So if it is not reauthorized by Congress, it disappears. So if you have any desire to engage in educating folks about how important F2F family engagement is, this is a good opportunity. So talk to your local F2F or check out the Family Voices folks. It's important that people understand how critical family engagement is. Part of what F2Fs do, part of their responsibility, is to train future family leaders. The example I know best is in Florida, where every year there's an annual Florida Family Leader Network meeting. And I was lucky enough to go and speak at the last one in January, and there were 120 families there. And it was an amazing 2 days of, advocacy boot camp, and how do the things we make a difference at the state level, and how do we learn from each other? How do we get clinicians to think about how important families are? So just in simple things like, if I'm a pediatrician and I'm doing a quality improvement program in my practice to, do depression screening, whatever it may be, if you don't have families involved in how you set up that new policy, it's not likely to be as successful. So we are funding this at the national level, and the state level, and through all of our grantees to make sure that family engagement is first and foremost across all the work that we do.
Thank you. So we have a question about the Propel programs from Maria Isabel. How does this new funding structure help jurisdictions that continue to need investment to set up downstream resources such as the U.S. territories?
Okay, so I'll try to answer that question, but please, if I don't get it right, come back to me. Remember that, first of all, that state newborn screening programs are a state financial responsibility, right? And one of the things that I see happen sometimes is that new conditions get added to a state newborn screening panel, but they don't necessarily, the Department of Health doesn't, or whatever agency it happens to be, doesn't necessarily get the additional resources they need. So remember that we are not at the federal level trying to replace that. States need to make sure that they are providing the resources necessary for a newborn screening program. What we're hoping to do with Propel and Co-Propel is have those extra funds that allow states to do a quality improvement project they really wanted to do, or take a step back or we need to do a one-time payment to get a new thing for a new condition. A variety of things like that. That's we're hoping that these funds are being used to do the extra things that state newborn screening programs, not just the lab, but also the follow-up folks, so they can do the things that they think are necessary, but may not be part of their day-to-day budgets. So that's part of the idea of this funding. We have, and this is the thing that's relevant for all of you. How did we get to this place? Across Maternal Child Health Bureau and in my division as well, we've for decades had wonderful programs like the Regional Genetics Networks that has all these cool projects going on all across the states. And they're amazing and they're wonderful, but they don't necessarily add up to much because we at HRSA are so small. We are tiny. So what we've tried to do is pool all of our money together in a way that can say, okay, we're going to now try to improve the system and how it works for every child with a rare condition. So we've tried to pool all of our genetics money together from a variety of things, including the RGNs, to be able to fund Propel and Co-Propel. And as I mentioned, we're getting up to probably, when we're through with this current cycle, up to about 42 states. We'd like to get to all the states and jurisdictions. So just like EDI or F2F, we're covering all 59. That's our goal, and we're going to continue to try to do that over the coming years. A lot, of course, depends on how Congress thinks about the world and what legislative authority they give to folks and what budgets look like in the future. So I don't know if I answered that question, but I tried to get there.
Yeah. So,
And let me know if I missed on that. Can I just actually say one more thing about that? Because I want to put it back in my public health, because I'm in California for the AMCHIP meeting, which just concluded. That's the Association of Maternal Child Health, Public Health folks, basically. We also sometimes get really interested in our particular conditions and the work we do. And so, Michelle and I spend a lot of time thinking about newborn screening because we think it's the coolest thing of all time. But I also heard that some of the Pacific Islands have 30, this may or may not be true, so be careful. This is just something I heard at the meeting offhand, have levels of iron deficiency anemia of 30% among mothers and infants. That's a public health emergency. right? That's like drop everything we're doing and make sure that mothers and infants are getting the nutrition they need, because I don't care how good your healthcare system works. If you're not getting the nutrition you need, nothing else is going to work. And it's hard sometimes for those of us like Michelle and I, who are deep into very specific rare conditions, to sometimes take a step back and say, there's this whole world out there. And if families don't get the nutrition they need, we're really missing the boat. So it's also helpful for all of us to sometimes take a step and say, yes, we need to make sure that kids with rare conditions get what they need. We don't want to lose track of that. But also we don't want to get so distracted that we miss out on things that are happening right in front of us. Sorry, just it's a Jeff sermonizing. That's not any HRSA policy. It's just like, sometimes I just get gripped by these things.
Sure. Another question that came through was how you're sort of engaging genetic providers as a whole in these various initiatives.
So genetics, that's I guess at the policy level, one of the things I would say is that we really try at HRSA, in my division in particular, not to do stuff without talking to people who are involved in it. And the genetics portfolio in particular, we actually worked with RTI, and they spent a huge amount of time and energy sort of surveying the field in a very formal way, doing an environmental scan, doing key informant interviews. So we tend to have those very formal processes. I also like the retail approach. So while I'm here in California, I've been meeting with people at Oakland Children's Hospital and UCSF, and I actually went to the clinics and just sat down and talked to some of the providers and asked them what's going on in your everyday lives. What are the families? What do you hear from families? And we also meet with families directly, just like that too, because I think, yes, you can have a contract to sort of survey the field, but sometimes it's helpful just to sort of talk to people directly. So obviously, I personally can't talk to every genetics provider in the country, but I do know a lot of genetic counselors and geneticists and other folks who do work in this area. And so we try to have a combination of formal, systematic input and direct sort of one-on-one, what do you think kind of stuff.
Thank you. So I think Maria as well did have a little follow-up question
Sure.
to the Propel question. She said, is there a thought to offer supplemental funding for those jurisdictions that need more intensive work to set up these fundamental systems of care that just pretty much aren't there yet?
Yeah, so we are in our Propel and co-Propel grants, and this is also true for our EDDI work. We really are trying to meet states and jurisdictions where they are. And some, and Michelle, I think New York State is an example of how you have this extraordinarily wonderful, complex system where you can do research and do this and that. And so you, right, in New York, can use that money to do the next thing. Other states and jurisdictions are just building and trying to set up a newborn screening program. So that's why these Propel funds, we're not saying you must do this with it. We're saying you as a state or a jurisdiction must figure out what are the things we need most. We do have some subject matter expertise, which is to say that unlike some other federal agencies where grant people may be experts in grant, here's the form you have to fill out, here's where your money line has to go, and so on. We do have a fair amount of subject matter expertise among our program officers and in our division, but we also recognize we don't have a lot. So that's where the TA centers come in, the technical assistance centers, and APHL is really our key partner for this. So we would then turn to APHL and say, okay, here's what you know way better than we do, how a state can bring a new condition onto the RUSP or start a newborn screening program from scratch. So we really turn to our partners in that sense as well.
Let's see. There's a question from Mabel. Conceived a baby via donor egg and sperm. Doesn't genetic testing differ in these unique situations in terms of funding and procedures that are available?
I think the answer to that is I don't know. Because I think you're asking about the differences in how the system works depending on how the child was conceived. So I'll say I don't know the answer to that. Yeah. I will say that there's a really interesting question. I will here again share my bias more as a clinician than as a HRSA person to what is the exact value and clinical utility of figuring out a genetic diagnosis. And I know I'm kind of stepping into the lion's den here, but as someone who takes care of a lot of different children, a lot of different complex conditions, I've had many families say, yes, I've seen, 3 neurologists and 2 geneticists, and they say it's, chromosome 15 on the short arm and it's this, But my main problem is my child's not eating, he doesn't behave, and I can't get the school to set up the program that he needs.
Right.
And so I think that there is real value in having a specific diagnosis. I see this all the time where families say, I was lost, I didn't know where to go, and now I know it's Angelman syndrome, and now I'm part of a community, and I feel much more connected. But I'm still trying to figure out how to get my child to eat, behave, and get the right school program. And a number of us are particularly interested in better defining what the clinical utility of a genetic diagnosis is. And clearly, there are some times where it leads to a specific treatment, or it leads to, oh, we need to do a renal ultrasound because we know there's co-occurring renal problems. But there's also this thing about, and in the world they call clinical utility and personal utility, and the philosophers get all crazy about this. But what is that additional value of, and not just for family planning, but also this sense that now this makes sense to me. Now I have a story to tell. Now I can begin to understand how to move forward to help my child. We've not done as good a job at measuring that and seeing how that fits in. And I think that's something that families can help us figure out better than anyone else. So I'm eager to hear more about that.
Alyssa was interested from the families that are on here to tell us in the chat of how it helped to get a diagnosis along those lines of what you were just mentioning, and we'll give that a minute. But going back to the Propel grants, how do you plan to engage genetic counselors in the Propel grants?
So again, the Propel grants are, and Co-Propel is probably something for you to look at even more closely, and that should be coming out soon. With the Propel grants, that was directed at states. So states were the ones who were applying for those. And so I hope that most state newborn screening programs are including genetic counselors in their work. And we certainly at our level, I mean, we have a couple of folks on our team who are genetic counselors by training. So that's a part of how we think about the world. It's a great thing about my team is that there's some people are public health folks, some people are clinicians, they have a variety of expertise kind of in-house. With Co-Propel, and this is what's coming out very soon, we deliberately made it open for other kinds of applicants. So universities and not-for-profits could apply as well, hoping that we would get a broader kind of interdisciplinary group thinking about things. And we'll see. This, as I said, we should be announcing all the winners of this in the next, I don't know, month or so. Actually, I shouldn't say what the timeline is because I really don't know, but soon.
Soon. That's a good answer. Yeah, I mean, there's been a big move even in my program to try and engage genetic counselors. And actually, some of the work that NIMAC as a region has done is to share with the genetic counseling profession how newborn screening could be a career choice, because it's somewhat novel, although it's growing in popularity. But we've gotten questions and actually give talks to some of our local schools about what newborn screening is and how that could be could be a career consideration. So I think we just need to keep that work up to share that newborn screening is a career choice for counselors.
Very cool. I love that, Michelle.
Any other questions? We're almost at time, so thanks for this discussion. If I missed anything in the chat. All right, so Lynn, who's been a long-term member of the NIMAC team, says that her family does not have a specific diagnosis, but manages complex care issues the best way that they can. With the closing of the RGNs, this takes away a pathway to feel connected to research and programs.
Yeah, and so I think this is sort of a good way to end. That I have to say, at a personal level, having been a part of our Southeast Regional Genetic Network, that I'm sad, right? There's no way around this. This is just sad to have programs end. And I hope that what I've been able to let all of you know is it's not because we don't value the work of what regional genetic networks have done over the years. We do think that by pooling our resources, which are tiny at HRSA, and focusing on trying to make the system work better for every child, we will continue to do a lot of the really cool work that many of you have been doing and create opportunities for that. But yeah, I mean, it's just sad to see some of the programs end, and they've done amazing work. I do believe, I mean, you can tell probably as you hear me talk, that we're doing really cool stuff. And every day I can't wait to get up and do the work that I do. So we have a fantastic team. We work with wonderful stakeholders like all of you. And there's no doubt that we can do better by families and their children. And so we're going to keep pushing as hard as we can. Thank you all for letting me talk to you guys today. It's been great.
Yeah, we appreciate your time. Thanks very much.